hello everyone, good afternoon, good evening, good morning, whichever the case may be for you in your locale. I'm your host of PerfWeb, Joe Basha, and we are here to do PerfWeb number 60. I'm very excited about today. Although this is a really intense topic, for me it's actually, notwithstanding some of the data I'll give you towards the end, it's an enjoyable topic for me. I've done a lot of work on this, and it's actually for me a pleasant conversation, albeit with unpleasant outcomes, but we could talk about that more. We're starting to show some reduction in our numbers as far as COVID. Actually, it's very low compared to what it was, but we still have some lingering patients who had been in the hospital for a while that we're still managing and dealing with on ECMO. So, but we are certainly seeing the numbers trend down, and I hope that is the case for everyone out there, and you all have done okay with this. Let me get through the quick notes. Want to make sure that we thank our sponsors, HET. I do need to tell everyone we have hired 4 people, so I am very excited about that. It seems that my notifications and that kind of thing, letting people know that we are hiring, has benefited us, and so I'm very excited about that. And I think we have 4 incredibly capable people who are really going to round our group out and give us the stability that we need in order to continue to provide the excellent service that we have, and then of course hopefully from there grow. That's our goal, that's our intention. Please make sure that you like us, follow us, share us on the Facebook, the YouTube, the Twitter, the LinkedIn, and all that stuff. Make sure you subscribe to our YouTube channel. That's actually very important to us. Give us a thumbs up if you would. You can actually open several accounts and give us as many thumbs up as you want. We've always appreciate it. But also, don't forget to hit that bell icon for notifications for when we do maybe a presentation that hasn't been previously scheduled or hasn't been scheduled for very long. So we're still planning some of these somewhat spontaneous things. So I would definitely do that bell icon. Our websites, perfusioneducation.com and perfweb.us. Perfweb.us is basically our schedule for all of our events through the rest of the year. We're scheduled out, I think, through August, and we're trying to get further than that. We want to make sure that we have good content that's timely, relevant, and we have the quality speakers that you expect. The Vanderbilt Faculty Forum has been going absolutely outstanding. I am so excited about that. The Tammy Sparacino Journal Club has now developed essentially a following of its own. The John Ingram Knowledge Nuggets has been hugely popular, and he has his own following. So, we've had some contact with some other folks, somebody in Spain who I need to reach out to. I haven't reached out to him yet. It's just because we're just so busy. But things are slowing down, so I'll be able to get to more of that. But we're really starting to see the movement that we were hoping for. I wasn't 100% sure which direction it was going to go or how it was going to evolve, but I knew it was going to be a grassroots movement, and I think that's what we're seeing. I am looking forward to doing the New Orleans conference in New Orleans next June, so if you want to pencil in on your calendars, I would probably do that. Likely will be more towards the mid or latter portion of June, but we're definitely going to bring that back. And so that's PerfWeb is our schedule. Perfusion Education is you can get a free membership. Go on there. You can look through our library. All of it's free. Membership is free. It'll even keep track of all of your CEUs if you want to add them in yourself. But if you want an account and you want CEUs issued by us, then we have very affordable pricing with either an unlimited plan, which is truly unlimited, or you have a pay-as-you-go, and all of your certificates will go in your folder. So you don't pay for the presentations, you don't pay for watching and learning or participating. You only pay if you need that CEU certificate. contact us at perfusioneducation.com if you'd like to send us an email. I've gotten several, gotten suggestions on topics, a variety of different things. Our call-in number, when you see this symbol, our phone lines are going to be open. We're going to try to open our phone lines, I think, early today. So if you want to call in, please don't hesitate to do so, even if it's in the middle of my presentation. I don't mind being interrupted if there's something that I'm either not explaining well enough, or you have other data, whatever. It doesn't matter what it is. You have a question, a comment, or you need clarification on something, you're free to call in and interrupt me. We're also, of course, going to have John Ingram, who I'll introduce here shortly, and he'll have no problem doing that as well, so keep it lively. I like that, as opposed to the just drone of one lecture. Make sure you check out our MediWeb app. So I might have to resync this, I'm not sure. So our MediWeb app is really cool. Do I need to remirror it? Yeah. So I'm screen mirroring right now. This is really cool. If you haven't already gotten this, I really recommend you do. And Magic, I do need to ask you this one question real quick. Can you tell me when we're going to do an update? Because we really need to do an update. I mean, I'm ready. So this is, because we do need to update things. But this is on either iTunes or the Google Store, so App Store or Google Store. But you see these two icons up at the top left. You have the Critical Care app, and you have the IV MedCalc. The IV MedCalc is actually in the Clinical Care Perfusion app, and I'll open that one up. But you can buy them individually, but the Critical Care app's $2.99, the IV MedCalc, which would only be germane for nurses dealing with IVs and IV rates and doses and so forth, would be found independently, and that's 99 cents. So I'll go ahead and open this up. And it has a variety of different things that you can utilize. It has a perfusion section. Of course, it always has to do an advertisement, right? Hopefully we'll get some advertisers one day. So it has a perfusion section, a hemodynamic section, an IV calculator, which is what I talked about just a minute ago. It has an Ecmo section, it has a clinical calculator, and it has a conversion section. So if we just, for example, go to, I'm not going to highlight the perfusion one this time, although I think I'll just very quickly go over it, but it has perfusion quick calcs, which will give you all of this information on the output section when you put that information in. So you'll be able to get your BSA, your BMI, your estimated blood volume, your red cell volume, heparin dose, estimated on-pump hematocrit, and your protamine dose, and of course all your calculated flows from 1.6 to an index of 3.0. So in the Ecmo section, for example, if we go back, it's very easy to use, it's very intuitive, it makes a lot of sense. But if you, for example, want to know what your arterial oxygen content is for the sake of this demonstration, put your hemoglobin is. We're just going to say that it's hemoglobin of 9. SaO2 is running, let's just say 95, and your PaO2 is 76. Calculate your arterial oxygen content is 11.86 milliliters per deciliter. That calculation would then help you in understanding what your DO2 is. So you know it's 11.86. Your cardiac output is, we'll say on the ECMO, is 5 liters a minute, and your DO2 is 593. It's red, or kind of a magenta color, I guess, because it's abnormal. If you click up in the little I section, top right corner, you'll see that it has the equation, it has the parameters, it has your inputs, and it has what your outputs are. 750 to 1,200 milliliters per minute is considered normal. If it was normal, then that highlighted number would be green. So I think it's a really cool app. I really hope you take a look at it. It has become more and more popular. I'm very excited about that. And it was not an easy thing to do, not an inexpensive thing to do, but it was, I think it has real value. So I hope you all will take a look at it. It's very appropriate for perfusionists, for nurses, for ECMO specialists, for physicians. In fact, we have a lot of physicians that buy it. So I'm very excited about that. Our podcast, please check us out on whatever streaming software you like. We've actually been contacted by people who are watching the podcast. I guess I will take just one moment to explain that the podcasts are not approved for CEU through the ABCP. You can listen to them, but the rules of the ABCP are, and they're actually on our website. If you go to perfusioneducation.com, it'll explain exactly what the ABC rules are. You can also go to the abcp.org and get all this information as well. But you really technically are supposed to be watching it in order to get your CEUs. Now, you can listen, certainly, and that's your choice. But I want to make sure that I clarify the rules. But the podcasts are really good. Look, this is educational. This is intended to help us learn. I think the information via the podcast is very useful. But the rules of the ABCP are what they are, and I'm obligated to make sure that you know that because I want to stay compliant and make sure you guys stay compliant as well, for those of you out there that are perfusionists. Okay, let me introduce the indomitable John Ingram. I think everybody knows John. He's been doing the Knowledge Nuggets, as I said, very popular, has his own following, and he is going to be joining us today basically to help me. Tammy is doing, she's actually had to do 2 cases in 2 different hospitals. As I said, we've been very, very, very busy, and the ECMO, of course, is so high resource utilizing that it's a real challenge. So I'm here in the studio by myself. I was feeling really weak about this whole thing, so I called John and said, John, is there any way you can help me? And John is always willing to do that. So welcome to the program, John, and thank you so much for helping me today so I don't have to try to do this all by myself. I can't hear him. Oh, you're muted.
Okay, there we go. So
there you go.
The wonders of live broadcasting, huh? So yeah, Joe. I mean, you can't do all the heavy lifting on your own, right? You got to have a little help once in a while.
I'm telling you, I need a lot of help a lot of times, and of course, without and I don't mean to be I'm not sure what the word. I find myself looking for words a lot lately, and I think I need to start taking Prevagen. But I don't want to say this gratuitously, but, without Magic and without David, this program I don't know what it would look like, but I think it would be disastrous. So I have to also give compliments to them. You, Tammy, everybody that calls in, Jeff Campbell and Eric Hunley, who recently won stuff that I sent. I sent a bunch of T-shirts and caps to the Netherlands recently, so they haven't received it yet. We're tracking it. Takes a long time for it to get there. Somebody that had called in. And so I'm really excited. I think that we're doing a lot of really neat stuff, John, and I can't thank all of you enough.
Yeah, we're starting to have peripheral contributors, people that, don't necessarily feel comfortable in front of the camera, but like my friend there, Alan Klima, who basically just decided to do something for the perfusion community and designed these really cool hats and shirts, and he sent you a whole box of them, without charge, and said, hey, I don't want to make any money. I just want to promote the field and promote goodwill, and here you go. So we take anybody who wants to, we take all comers. Somebody wants to come and talk or be on part of the panel or just phone in or come once and try it. I mean, it's all good. We're all learning here. We're not here to teach anybody anything. We're here to learn just as much, right, Joe?
Well, no, I think we're I think we're here to teach people things. We have a lot of experience, but just because we're here to teach people doesn't mean we can't also learn.
Yeah,
I think that's what you really meant to say. Yeah, no, we actually are here to teach people things. I think that is our purpose.
You were searching for words. I'm now searching for thoughts.
I understand. Well, I'll share some of my Prevagen with you. Okay, yeah. So as I said, this is for me kind of a fun presentation, and you'll understand as we move forward as to why I feel it has such incredible gravity. So let's go ahead and throw my slides up, and we'll just go from here. So my presentation is veno-venous ECMO validating RESP and PRESERVE, and these are scores, and I'm going to go over all of that with you. The perfusionist role in COVID-19. So it's sort of and the perfusionist role in COVID-19. Tammy helped me a great deal with this presentation, so I want to make sure that I give her recognition for that. And neither myself nor Tammy, and I'm confident neither John nor John would have any disclosures in regards to this presentation. So the use of ECMO for respiratory failure really became in vogue and much more recognized as a therapeutic modality back in 2009 with the publication of the SESAR trial. And if you remember, we had the H1N1 pandemic, and we had a lot of patients who were suffering from respiratory failure, and these guys, Peake and colleagues, put together a paper on the efficacy and economic assessment of conventional ventilatory support versus ECMO for severe adult respiratory failure, or ARDS, and it was a multi-center randomized controlled trial, and it showed very favorable outcomes. So this is really the launching point. Now, we can argue the validity of the SESAR trial all you want, and there are some that look at it and say it was a very poorly done trial, and there's other people that swear by it. And I'm not actually here to debate this either way. My only point is that this trial is what showed veno-venous ECMO had the ability to provide the environment, oxygenation, and time for patients to recover from this severe acute respiratory distress syndrome and respiratory failure. The RESP score came later, and we're going to go over the RESP score, so I'm actually going to click on this, and it will go ahead and open it up. So the RESP score was developed by ELSO and the Department of Intensive Care at the Alfred Hospital in Melbourne, Australia. And the RESP score numbers, so if you look at this tool they have, in the top left, of course, you have information about it with the author, primary author being Schmidt. When you look at the top right, that's the patient's RESP score. When you look at the left, you have your graph, which is going to give you your confidence interval of 95 and 99%. And then on the bottom right, the larger of the sections, you have your inputs. So if I say this patient is greater than 60 years, 60 or greater in age, you see that just off of that one piece of information, you have a RESP score, and you see it over here on the left. And let's see, will this work? Oh, that won't work. I can't write on this. Yeah, so you'll see the RESP score with the 90 with your confidence interval section. If I change that to a patient of 50 to 59, you see that their survival actually improves. And if we have an 18 to 49-year-old, it's even more improved. If we take that same patient that's 18 to 49 and we make them immunocompromised, you see their RESP score in the top right goes to -2 from a 0. And you saw on the bottom left how their score shifted to a lower survival. If we take that away, you'll see their score goes back to 0. And basically, they have between a 40 and 60% chance of survival just based on their age. If they were on mechanical ventilation for less than 48 hours, you see their actual survival has improved dramatically. Okay, because we're giving it more information. Now it can kind of predict. We just did age to show you how everything moved around. If it was 48 hours to 7 days, you see that your RESP score went down to 1. So let me go back to that. You see the RESP score is 3, and you see where your survival range is. Now you see RESP scores 1, and you see your survival. And if it's greater than 7 days on ECMO on mechanical ventilation prior to ECMO, you see that your survival gets a little worse, and your RESP score goes to 0. If it is a other acute respiratory diagnosis, you see that kind of bumps you up a little bit. You have RESP score of 1. And I'm going to tell you right now, immunocompromised, watch that. It goes down, see, and then back up. So that's actually a 2-point change. If you have central nervous dysfunction, you can see that that makes a huge difference. You go all the way to a -6. If you have a non-pulmonary infection, an associated non-pulmonary infection, you see that your score gets a little worse. If you were on neuromuscular blockades prior to ECMO, you actually have a better chance of survival. That's how critically important this is. If you use nitrous oxide, however, before use of ECMO, you see your score actually goes down a little bit. If you needed a bicarb infusion, it goes down a little more. If you had cardiac arrest, it goes down a little more. You notice now it's a negative number. If your PaCO2 was greater or equal to or greater than 75, it makes you down to -4. And if your peak inspiratory pressures are equal or greater than 42, you're all the way down to a -5. So if you take those same issues, the same situation, and just make the person a little older, it goes all the way to a -7, and you see the correlated survival also went down. And if they're equal or greater than 60 years old, your survival goes way down from there. And again, your 95 and 99% confidence intervals are there. So keep that in mind, but you're a -8. So that's how the RESP score works. It's the more negative your number or the lower your number, the lower your chances of survival. And this is very easy to find on your on the website. So you could look it up, RESP score, and it'll show right up. Now, in contrast to that, and actually done a little bit, if you look at this, this was done in 2014. In 2013, the same author, this is Schmidt, did the PRESERVE score, and this was done in France. The PRESERVE mortality risk score and analysis of long-term outcomes after extracorporeal membrane oxygenation for severe ARDS. And this is actually a positive number. So the lower your RESP score, the worse it is. The higher your PRESERVE score, the worse it is. So it's completely opposite, okay? So if you take a patient, and I can say that let's go ahead and make our patient between 45 and 55, you see that I can put a 2. This is very strange. The patient with a body mass index of greater than 30, and we're going to talk about that a little bit, is actually considered an improved opportunity for survival. So we're going to take that -2 and subtract it, and we're back to 0. And then if you take PEEP of less than 10, you can add 2. And if you have plateau pressures greater than 30, which we frequently do, we add 2. So this person's RESP score is going to be 4, right? So keep that in mind. Now, focusing back, and let me go ahead and erase that. So focusing back on this right here, this BMI greater than 30 is actually a positive thing. Remember, the higher your number in PRESERVE, the worse it is, opposite of RESP. So you're subtracting 2 for these larger patients. This is actually predicated on citation number 46 from the original paper that was written for, published for PRESERVE. Notably, and I'll go ahead and read it to you from here, notably, BMI greater than 30 kilograms per meter squared was associated with better outcomes, independently of pre-ECMO peak, plateau, and PEEP. So PEEP pressures, plateau pressures, and PEEP. Although it has frequently been reported that obese patients have better ICU outcomes than normal weight patients, 46, this observation might suggest that plateau pressures might not be a valid surrogate of transpulmonary pressure in obese patients for obvious reasons. In obese patients, and therefore might not necessarily mean more severe respiratory failure because their chest wall elastance is higher than normal reference values. So obese patients, and again, it's predicated on citation number 46, and their thought is, well, wait a minute, this increase in mass, especially the big belly that's pushing up on the diaphragm, all these various factors, may not actually, we have these high plateau pressures or peak pressures, either one, and it may not be related to a loss of lung compliance. It's actually due to this additional weight that these patients have and applying a pressure to the thoracic cavity for expansion and for the ventilator. So keep that in mind. And to sort of validate this, and I took this, kept going down the rabbit hole with this, this is the actual article. This is reference 46. Lower short and long-term mortality associated with overweight and obesity in a large cohort study of adult intensive care patients. Excellent study. So they excluded neonates and children. They excluded adults without a hospital ID or clinical data. That was 711 of them. They removed 2,000 adults, plus or minus, without weight data from the primary analysis, and they ended up with 16,812 as an N. That's a big number. And indeed, if you look over here at this graph, you can see that down here, underweight is red. They fare very poorly. Over here is normal weight, and that's this line right here. They do a little better than underweight. And then the remaining numbers are overweight and obese, green and dashed green and dashed blue. And you can see here that their outcomes in 30 days was much improved from underweight or from normal weight. And that's very interesting. But the problem with that is these aren't ECMO patients, nor are they ARDS patients. These are just ICU patients. So the PRESERVE score is predicated on patients who are in the ICU for all kinds of things, but ARDS and on ECMO. So you have to take that with a serious, you really got to look at that very critically and consider whether or not you really should be subtracting 2 points from that score because of the BMI being greater than 30. I can tell you from experience that BMI is greater than 30. Certainly BMI is greater than 40. If they're greater than 40, they are definitely not doing better than patients that have a BMI of 28. I can assure you of that just from my own eyeballs. And we'll talk a little about that.
Joe, you want to have a little conversation briefly about this?
Absolutely.
As to why you think and why people might think this is perhaps the case. I think we had a PerfWeb several back where a little bit of this conversation came up about obese people doing better actually after cardiac surgery, not necessarily ECMO. And what we found out was that obesity is an inflammatory state in and of itself. These people live in a mild to elevated inflammatory state, and what happens is they're hypercoagulable, and therefore they have less blood loss in the ICU and require less blood transfusions, and that in and of itself is a big complicating factor. And I think also I think that their blood volume is probably larger, and therefore their hemodilutional factors are less, and again they require less blood products. I think we need to be clear to our audience to not go out and attempt to be overweight and obese and think that you're somehow medically going to benefit. I think there's a whole slew of negatives that would counteract some of that that we were talking about in the previous perf. What are your thoughts?
No, I completely agree with you, but I think there's a point, right? I think there's the traditional well-nourished male or female that when we say well-nourished probably means they're carrying a little extra weight with them. Then there's the morbidly obese patient who is, 500 pounds and just, or 400 pounds and just fat, period. And then there's the big person, like a lineman for an NFL team, who's an enormous person. They look like they're fat, but they're not really. They're fat, but they're not that fat. They're very marbled in their muscle. And those people, I think, are just a completely different category. And then you have the malnourished, undernourished, cachectic person, on the far end, the extreme. Certainly, I think when you look at these people, the malnourished, undernourished people tend to have hypoalbuminemia, and there's all kinds of third spacing problems and volume issues, and you're right, their total blood volume is low, so the dilutional impact of the pump is much higher, and they have no reserve. So I definitely think that a patient who is a fairly decent physiologic specimen, for example, our very first COVID ECMO that we did, who walked out of the hospital, who was a police officer, who was, doing at least some, exercise. They weren't necessarily working out like they are now, but they were doing something. And they did very well, but they were treated very early, and we can talk more about that as we move forward. But if you take a person who, again, is morbidly obese, you can't ventilate them. Cannulation is challenging at best. Getting it positioned in the right place and keeping it there, being able to turn that patient, skin breakdown, secondary infections, I think that's an extreme. And then you have the opposite of people who have zero reserve because they're, just malnourished and they're sickly. So I think there's a lot of factors involved, and I'm going to talk more about that as we move forward with our own experience. But I agree with you 100%. You want to add to any of that?
Yeah, I think there's three factors, and there may be more. I'm not an expert on obesity, but you have an increased blood volume, which is exposed to less hemodilution, less an effect of hemodilution. Then you have a hyperinflammatory state, mild hyperinflammatory state, which causes them to be hypercoagulable. So in a regular case, it's been documented that they bleed less out of their chest tubes post-cardiopulmonary bypass. And the third thing may be, when you're just talking about nutrition, is obviously somebody who's carrying a lot of extra weight. What is fat essentially? Yeah, well, it's an energy store. That's what your body's doing. It's storing energy for a day when you don't have food to eat. So these people have the tolerance to be, without, sometimes really you go, if it's not an emergency case, you have to be, NPO after midnight. So maybe you didn't eat the day before. Then you end up not getting nutrition maybe for another day or two. So you have like 3 days there maybe or so without any nutrition. Well, a heavyweight person has got this enormous energy store they can draw from, and a fit person doesn't have that. So perhaps those three thoughts come to my mind as to why somebody with an extra weight, could do better. Now, ECMO, I can tell you, I don't know that all those are an advantage a lot of times.
Yeah, well, we're going to see, because I've got some interesting caveats. But I will add a caveat to what you just said. I think there's well-nourished, somewhat overweight, obese, BMI 30 to 35-ish, and then there's a BMI of 60. And I don't think they're the same thing. So I think you can be, I think that depending on what you're going to have done, cardiac surgery, easy chip shot, valve replacement, whatever it is, versus a long-term need for either total respiratory support or circulatory support in those patients. But anyway, let's go ahead and go to the next slides. So in PRESERVE, you saw the RESP. We're going to go over these numbers. So as I said, that patient that we did ended up with a preserved score of 4, if you remember, and that's here. And that basically, this goes all the way out to 180 days. And in that particular case, their survival is just under 80%, so somewhere around 78%. With a preserved score of 5 to 6, you see that their 6-month survival is down to around 58% or so, and if their preserved score was 7 or greater, you see that their 6-month survival is down under 20%. So, you know, it's easy to see that initially you have pretty decent outcomes, but then as time goes on at 6 months, and historically we really don't look at that, but you know, at the end of the day, it's pretty important. So you may have at 30 days, you survived over here at 80%, a little over 80%, but as you track that out, it goes down to, you know, somewhere around, it looks like about 55 to 58% survival. So a pretty big difference from 30 days to 180 days. And then you have this, which confounds even more of all of this discussion. Here is an 18-year-old survivor. Now, the key information here, the key part of this demographic is 18 years old, okay? Can't take that, that's a very key element. But with a body mass index of 73.9, it is the largest person, and this was Bavita and colleagues who wrote this. I'm not exactly sure where it was from, but it was published in Critical Care Explorations by the Society of Critical Care Medicine very recently, and it's the largest COVID with ECMO or ECMO for COVID survivor that's known. And they do talk about the patient being discharged to home after a rather protracted hospital course, both a long ECMO run and a long hospital course before going home. And they didn't go home without a lot of care and essentially unscathed. I don't know how that patient is doing now, but certainly this was a real challenge. And I'm sure that it was a very emotional decision for the clinicians that made the decision to put this patient on ECMO, because a BMI of 73.9 is very, very, very large. And I have no doubt that this was a real challenge. I suggest you read the article because you can see all of the various things that happened to this patient as their hospital course went on. And I think these guys did an incredible job at being able to get him through this. But at the same time, we have to look at that 180 days out and really understand what did we do. And that is a deep, very deep ethical dilemma that we have all been facing for about a year. And I'm not sure where I fall on this. I have conflict in myself with what to do with some of these patients and what I think is right and what may not be right. I'm of course, none of us have a crystal ball, but we can discuss that a little further as we move along. Going back to PRESERVE, and this is some very interesting data. So in this column here, you see these are alive. This is just their total patients. This is alive, and this is dead in PRESERVE. BMI that was 29 versus 26, so the little higher BMI seemed to have better outcomes, and this was statistically significant. You also have patients who had previous H1N1 infection, and actually 36% of them did. 30% of them were alive. 6% of them were non-survivors. You also notice here, again, same exact setup. This is just the second part of that same chart, alive, dead. You have 32% were alive with plateau pressures of 32 versus 34, so lower plateau pressures seem to make a difference and statistically significant. hospital admission to ECMO initiation, you'll see that you have a much better chance, actually 5 days, please forgive me, 5 days in the alive, 13 days in the dead, statistically significant. So shorter time from hospital admission to ECMO initiation, shorter time from ICU admission to ECMO initiation makes a big difference in whether you're in the alive or dead section, and that's all statistically significant. And days of mechanical ventilation, shorter days versus longer days, made a statistical difference in whether or not you were alive or dead. So plateau pressure is lower, time from hospitalization to ECMO initiation, lower is better. Time from ICU admission to ECMO initiation, lower is better. Days on mechanical ventilation to ECMO, less days is better. So lower is better. Keep that stuff in mind. This is an important chart. Now, Brunet, also in France, and forgive me, let me turn this off. Brunet from France took the RESP and PRESERVE scores, him and his colleagues, and decided they wanted to do an external validation of these two scores, both RESP and PRESERVE. And this is very important at what they came up with. So if you look here, this is RESP done by Schmidt, okay, and PRESERVE is Schmidt as well. Class 1, they had a 92% survival. In the cohort from Brunet, they didn't have any patients that met Class 1. In Class 2, RESP had a 76% survival. In their cohort, Brunet, they only had a 50% survival. Class 3 was 57% in RESP versus 43% in the Brunet, in the cohort from them. Class 4, 33% versus 20%. And Class 5, 18% survival in RESP, 50% survival in the Brunet study. Now, it's important to note and point out, look at the total number of cases, 164 versus 0, 563 versus 6, 1,033 versus 14, 449 versus 5, and 146 versus 2. So clearly, RESP has a much larger number, but keep in mind, it's coming from all over the world. This was a single center looking to validate the score to their actual outcomes. So it's very important to point both of those things out. I don't think the lower numbers invalidates it because, again, they're doing a validation based on a prediction from that score. When you go to PRESERVE, 97% survival in Class 1 versus 58%, and much closer numbers, 34 to 12. 79% survival for Class 2 in PRESERVE, in their cohort 54%. Class 3, 54 versus 57, a little bit better. And Class 4 was 16% versus 0. So what they went on to say, and this is very, very important. This comes directly out of that paper, and if you'll permit me to read it. The selection of patients with severe ARDS most likely to benefit from ECMO remains a difficult challenge for physicians, clinicians, practitioners. Based on large retrospective observational cohorts, 2 predictive mortality scores have been developed, the PRESERVE score and the RESP score, both having good performance in helping physicians to select the most appropriate candidates for ECMO. That is the current knowledge. What did this paper, in their words, contribute to our knowledge? And this is the most important part. In comparison with original cohorts, we report poor performance of these scores to predict death in subjects with ARDS receiving ECMO with different case mixes. Therefore, this study suggests that great caution is warranted when considering these scoring systems, meaning RESP and PRESERVE, to individually select patients with ARDS for ECMO. You got to use your clinical judgment. The scoring may be a good guide, but in the validation of those scores, my own experience using those scores, I can appreciate what Brunet and his colleagues saw when they used these scores in their own patient population and then compared the predicted outcomes to their actual outcomes. John, do you want to add anything? Oh, wait, 1 second before you take it down. COVID sucks, people don't, but there are exceptions. Okay, so you don't suck though, John.
Yeah, yeah, I'm not sure what to say about that, Joe. The large trial, multi-center trial, gives those numbers. They put you in the ballpark, but remember, one big thing that comes to my mind is that you can walk, and you see this there in Houston, I'm sure, with the number of centers that are doing ECMO that you're exposed to. The CCM approach is different. The critical care medicine approach is different. Hospital to hospital. The surgical cannulation approach is different hospital to hospital. The nursing care, when I'm talking about ECMO now, because ECMO is so multidisciplinary, intense, and people's idea of how many meds they're on and how much to take off fluids.
Anticoagulation strategy. Anticoagulation
Right.
strategy. Are you measuring recirculation? Yeah. Are you measuring oxygenator blood volume? Are you paralyzing the patient? Are you waking the patients up? Are you trying to mobilize and exercise these people? What's your target hematocrit? Are you allowing for, much more anemia than I'm comfortable with? Or are you very liberal in your transfusion? And how much trolley is associated with transfusions? And I mean, the list goes on and on. Did they develop a pneumo? Did you put a chest tube in? Did you hit an intercostal and you're anticoagulated? Now, what are you going to do? You're bleeding severely. Trauma to the nasopharynx, the oropharynx, putting different tubes down. We're dealing with that right now. And we held the anticoagulation. It was at a hospital where we aren't doing minimal anticoagulation strategy, non-unfractionated heparin or Angiomax. And we went ahead and held the anticoagulation for 6 hours because she was bleeding so profusely from her oro and nasopharynx area. And then she had a big, giant left-sided effusion, pleural effusion. And we tapped it, and we got out thick, really thick blood. And it was about 900 to 1,100 cc's. So, there's a lot that goes on with these patients. And this is a relatively, she's a little overweight, but not bad. She's unfortunately not a transplant candidate, though they're trying to get her on a transplant list. She's from California, and she's 40 years old. She just moved out here. She got COVID, and she's in the ICU in a lot of trouble. But we did hold her sedation, and she did wake up, and she did follow singular commands. So, we got to do everything we can to help her. She doesn't have a pneumo yet, so hopefully she won't develop one, and we can actually get her, through ECMO. But even getting her through the ECMO and transition to just mechanical ventilation is only the beginning of the struggle, because again, you got to get the patient extubate. She's on trach collar now, but you got to get her to where she's no longer dependent on the vent or oxygen. Keep her from going into multi-organ failure. Her kidneys are still working, but her BUN was elevated. Her liver's still working, but her enzymes were bumping up a little bit. That might be secondary to the ECMO. It might be secondary to some other, issue going on with her that is yet to be identified. But, there's a lot that goes on with these people.
Yeah, I mean that one graph you put up there when you showed when you highlighted in red there, and the one thing that sticks out is on the statistics there where the average mechanical ventilation days mean was 3 and the other one was 7.
Yes, made a big difference in
I
survival.
know there's other factors there that are significant, but that one hits it out of the park. You can't have less than the 3. You could double 3 and you still didn't reach 7 on the other one. You know what I mean? It's a pretty big difference, and that stood out to me as a pretty big, probably the biggest one. But there's so many things, and that's why you take this one group there. You're talking about trying to compare their experience with the big numbers, and they were kind of in the ballpark, and the trends of it were there on some of them, but everything could be different. The care from A to Z could have been different than any number of the patients that they were comparing
Well,
to.
that's true, John, but you can't, I see your point, and I think your point is very valid. But when you're looking at a predicted score of 76%, this patient should do great. But then you take, and that's from this multi-center international database, and you have that high number, N that you're comparing it to, and all these other factors that you just articulated very clearly. But then you look at your center, and ours is 46-50%. That's a huge difference from 76%.
Yep.
So, are we really, or worse, you're even lower than that. So your ability to predict survival from these scores has to be taken with a lot of skepticism, in my view, even though it's a starting point, perhaps, but I think you can't hang your hat on it and say this patient, by prediction, has a 76 or a 98% chance of survival with this. We have to do it, because I don't think you can really say that.
Yeah, I hope that centers that see themselves at 20-30% below what seems to be the what everybody else is doing, or a large average of what everybody else is doing, if they'll reach out to find a center that is doing those numbers, and reach out and have their ECMO leaders reach out to them, or maybe go spend a day or 2 or 3 at that center and try to dig up what it is they could do different, and try to improve that. I think we all have to learn from each other, because if we all have to make the same mistakes over and over to get to the same point, we're going to be at this an awful long time.
Yeah, well, I can tell you this. RESP and PRESERVE are no way comparable to the detail and the I'll say accuracy, but specificity of the STS mortality risk score for cardiac surgery. That's as comprehensive as it gets. We're nowhere near having that level of sophistication in either of those scores. So I think that is my takeaway message, is that those scores are good scores to have, to know how to do them, to know what's important, to look at all of this data, but you have to look at it with some level of skepticism and ask yourself, is this really the right patient for us to do this to, and what are they going to look like in 180 days, not in 15 minutes, because we put them on ECMO and everyone looks better in the short term.
And that other graph you had that showed the 180 days graph that you're talking about.
PRESERVE.
If you look back at day 20, I know you highlighted, you think you circled day 30, but if you look right at day 20, you'll see that almost every one of those jumps down. There's
Big
like
drop.
a waterfall drop off right about day 20. And we have a lot of conversations at our hospital about somebody who's on ECMO for about 21 days. Are they showing signs of improvement? And certainly at 30 days, we give the COVID patients, you got to give a little longer. But if you're not seeing any improvement, hardly at all, and the conversations need to start with the family. I think we do every 2 weeks, a very serious conversation. Hey, we've been 14 days on ECMO. We have not seen any improvement. I think it would be better if it was 7 days at most places, because by the end of 30 days, the family has now heard for 4 weeks in a row, there has been no improvement. And 30 days for a young person is not a long time to get better from a serious disease, but it's getting to be a long time on ECMO. You're getting up there.
You are, and and as I said, it's a very difficult situation because these patients are young. They're they have young children at home, or they have they don't have children yet. They have parents, spouses. It's very emotional, and I understand that. I think that we definitely have to give people an opportunity, but you also have to consider what is going to be their health-related quality of life after this is over. If they survive, what will that actually look like? And we're not in the business. We're in the business to save people. We're in the business to help people. But there are fates worse than death. I mean, at the end of the day, and I think these are ethical dilemmas that I don't think I can solve. And frankly, I can have an opinion, but I am very glad I don't have to make those decisions in a moment, in a vacuum. I'm able to sit here and pontificate it in the comfort of an air-conditioned studio, not standing in front of somebody's spouse, children, or parents. So, it's very tough. But let's move on. I think I've got some interesting information. So, the way I feel we sort of need to think about this is that you got the green light, there are clear indications for ECMO. You have a red light, that is, it is clearly not indicated, but you have the yellow light, which is, let's see, why won't it work? Do I have to do this? Yeah. Which is where your clinical judgment comes in. And the yellow light is, that area is much bigger than the green light or the red light. So you spend a lot of time in the yellow zone. So when somebody's contemplating putting somebody on ECMO, this is what I want you to think about. You can see there are red lights blinking. You can see that there's a barricade on both sides of the street. You can see here, and you can't read it, it's a little fuzzy, but it says, "Do not stop on tracks." So I'll play the video, but this is the image I want you to consider when people start talking about putting people on ECMO for COVID-associated ARDS. Okay, let's think about this, whether we should do this. This is where you should be stopping and thinking. I know y'all saw it coming from a mile away, but you really have to take a moment, notwithstanding the patient may be coding at the moment. Of course, that's a completely different thing. Oh, here is the image from the actual train. Well, there goes the car. So think about it. I think that's kind of where I'm at with this is, you can't have a patient that's been on the floor for 12 days, struggling, becomes a rapid, comes to the unit, gets intubated, lingers around in the unit for another 3 or 4 days or 5 days on the ventilator, finally is just deoxygenated and CO2 is through the roof and they can't ventilate the patient anymore at all, and now we're going to put the patient on ECMO. I can predict. I don't need the Resp Score nor the PRESERVE score to predict that outcome for you because I've seen it so many times. So in 2020, based on what's going on, ELSO developed a consensus document. This is very important. We need to see this. And I highlighted some of the various different things, but they recommend against initiation of ECMO for maximizing traditional therapies for acute respiratory distress syndrome, in particular prone positioning. Now, this is the consensus statement. I don't completely agree with it. I kind of agree with it, don't completely agree with it, because I think if you follow this to its letter, so to speak, versus its intent, which is to try and preserve resources for the most survivable of the patients, and you do try all of these things and keep trying and keep trying and keep trying and keep trying, you get farther and farther and farther away from what is the window of being able to protect the lung, and the lung becomes so injured, so inflamed, so damaged that it becomes irreversible. So I wanted to highlight that. There's a lot of other data in here, but I just wanted to point that out. Again, I highlighted those things that I wanted to demonstrate or to talk about today. In terms of veno-arterial ECMO, indications and patient selection criteria for VA ECMO should not deviate from pre-existing guidelines. Timely provision of VA ECMO is recommended before development of multi-organ failure. We all understand that. You have low cardiac output syndrome, and you're sitting there on multiple pressors. You know, you're going to go into multi-organ system failure. Consider VA ECMO in selected patients with refractory cardiogenic shock, persistent tissue hypoperfusion, and systolic pressure of less than 90, cardiac index of less than 2.2, while receiving norepi at greater than 0.5, and dobutamine at greater than 20. Also, patients requiring VA ECMO support who incidentally test positive for COVID-19 but are not thought to be critically ill due to the virus should be considered for ECMO support in the usual fashion. So you can have a patient who is COVID positive, is someone who is an asymptomatic COVID positive from COVID, but had an MI for a different reason and needs mechanical circulatory support. So their COVID diagnosis should not preclude them from that. I've shown this slide multiple times. I want to show it again for the sake of this audience and anyone else that reads this or watches this. And this is an algorithm or a nomogram, whatever you would call it, that tells you what to do for various different circumstances. And I'll explain why I bring this up. So if you have refractory hypoxemia, so all of your strategies to ventilate are failing, and you have cardiogenic shock, then you should follow this line down with cardiogenic shock. You have to ask yourself, is the cardiogenic shock due to other heart failure, or is the cardiogenic shock due to hypoxemia? If it's due to other heart failure, veno-arterial ECMO or veno-arteriovenous ECMO is appropriate. But if your cardiogenic shock is due, and I'll follow this down, due to the hypoxemia itself, please don't put that patient on VA ECMO. That patient should go on V-V ECMO because the oxygenation will result in the heart function improving. But if you put a patient on V-V ECMO that has trashed lungs but a good heart, you get this problem over here, differential hypoxemia. This is, of course, if you have peripheral cannulation, fem-fem. So your lungs are trashed, you have isolated respiratory failure, but your cardiac function is really good, and you do veno-arterial ECMO with femoral arterial return cannulation, you will end up with everything from the diaphragm down, being nice and pink, and the head, and ultimately the heart, the brain being the most sensitive. You're basically going to have a hypoxic brain injury, and that patient's not going to survive. The heart will quit but it'll be long after the brain is toast. So if your respiratory failure is pure respiratory failure, even if you are showing signs of cardiogenic shock, but it's because of the hypoxemia, then you do veno-venous ECMO alone and correct whatever cardiogenic shock you have, and you have the patient protected as the heart's contracting and beating normally again. John, any comments about that?
Yeah, I noticed that you added the veno-arterial venous on that one box, which I love.
Yes.
Because I love V-V ECMO there on the lower left. We could talk about,
yes.
But
well, I didn't add it. The authors. It comes out of the ELSO Red Book.
Yeah.
Right here.
Well, that used to just say just VA at one point, did it not, or did it always say the VAV?
No, it always said that.
Oh, okay. I missed a note. So the
I just never mentioned it before.
Yeah, it's an old slide, so that's a good slide, though. I love it. The thing that over the years now and all the almost close to probably getting close to 1,000 ECMOs that I've seen, getting up there anyway. I'm beginning to here in the last few months with all the ECMOs that I see, that one of the first things now used to not be even in the top 5 things that would pop into my mind is, regardless of VV or VA or VAV, I want to think to myself, what is the oxygen quality of the blood coming out of the left ventricle? Mm-hmm. Whatever we're going to do here, right, Joe? Whatever we're going to do here, what ends up coming out of the left ventricle? Is it going to be oxygenated? Is it going to be oxygenated enough by what strategy we're doing? If you're doing VV and you still don't end up with enough oxygenated blood coming out of the left ventricle, you're hypoxic, right?
Your best chance for analyzing for being able to infer that, your best choice is the right radial. Now that can still exclude the coronaries, but likely not. If your right radial is a good saturation, good PO2, more than likely you're getting great oxygenation to the brain and to the heart as well. But your best ideal would be to have a catheter in the aortic root just above the aortic valve.
I think the saving grace on some of that is that we're offloading the heart with this, and the heart ends up working maybe less strenuous, although that doesn't have to be the case. It could be worse if you have AI and you're doing VA.
Sure, but there's a lot of people who have heart, from cardiogenic shock, that when you unload them, I've seen it how many times in the operating room. You're on pump, the heart looks like it's beating great. You go to load it, and it does terrible. Yeah. So you're on veno-arterial ECMO, and you're decreasing preload, and of course, that's going to provide for the heart having less volume, and it may beat a little bit better, and you're actually ejecting now where you weren't before, or worse, you put an impella in on top of it, you have trash lungs, so you've got a great left ventricular unloading, but everything coming out of the left ventricle is desaturated, and everything going up the femoral artery is great. So if you draw your systemic, your patient blood gases from the contralateral femoral artery, it looks fantastic, but your patient is still has anoxic brain death.
Yeah, I mean, it's really central to what you're doing is what is the oxygen and really carbon dioxide level too, but oxygen level content that is coming out of the left ventricle, VV or VA or VAV. What is that number and what is coming out? Because that's what's going, to the coronaries. That's what's going to the heart. So if you're inadequate on your VV, and Joe, we've done now. We had a few more just this last month where we had VV, and we had 2 more where we had 2 separate cardio helps, one on VV of one style on the same patient and another VV, and we also had a VV and a separate VA on the same patient because we could not capture enough either on the VV due to their hyperdynamic cardiac output. We're not capturing enough, or the location of the cannulas, we couldn't eliminate enough mixing, or what have you, or they just had so much volume on board too. That's another thing. You have very hypervolemic patients. They can have a tremendous cardiac output that's flowing through there. And so, in the end of the day, we're doing all these things, and we draw a right radial, blood sample, and the PO2 is still, in the 50s or 40s or something. And here it is, we have all this tremendous efforts to oxidation going on, and we're still not getting great number on the.
And
on
if
the
that's
right,
the number here, that's the number the brain is seeing.
Yeah.
No question about it. So anyway, I'm going to run out of time. So let's go through the rest of these slides. I think we can get through these. I've got a lot of slides, but this is also from the ELSO consensus statement. If your PF, PaO2, FiO2, otherwise PF ratio is less than 150, they strongly recommend prone positioning unless contraindicated. And some people are just not compliant with it. They can't do it. They recommend neuromuscular blockade and appropriate PEEP. Consider inhaled pulmonary vasodilators, nitric oxide, recruitment maneuvers. If you have any of these, PF ratio less than 60 for greater than 6 hours, PF ratio less than 50 for greater than 3 hours, pH of less than 7.2 with a PaCO2 of greater than 80 for greater than 6 hours, and you have, if it's no, current management. If it's yes, you should look to ECMO. Is there a contraindication? No, then they recommend ECMO. Yes, then obviously do whatever you can. And here, if your PF ratio is equal to or greater than 150, but your pH is less than 7.2 and a PCO2 of greater than 80 for 6 hours, and if the answer is yes, contraindications to ECMO, no, they recommend ECMO. If no, then obviously current management or if there are contraindications. So another very important slide to use, a good guide to help you make the decision, not an absolute, help you make the decision. Also, their relative contraindications, which is on the top of this page, age equal to or greater than 65. Now, a relative contraindication for them is a BMI of equal to or greater than 40. I think that's very important because that is in direct conflict to their RESP score or PRESERVE score. So you have to take that again and keep that in mind. The absolute contraindications, which is here, is any contraindication to anticoagulation. I don't really agree with that because we're now doing a lot of these cases, John, and you've helped me a great deal with this, with no anticoagulation, and we're doing it successfully. Inability to accept blood products. I'm not exactly sure what that means, but it sounds to me like not inability, but unwillingness to take blood products. And again, I'm not sure that that is a direct contraindication to ECMO, but something to certainly consider if the patient's going to need it. We do cardiac surgery. I can't hear you, John.
I'm talking to myself, actually, but
yeah.
I'm just thinking, I can't recall us doing, if they're referring to Jehovah's Witness patients, for example, I'm trying to recall if we've ever done one. I can't recall one.
Well, we do cardiac surgery on them, and that's pretty risky. In this, it has to do with capacity, conventional capacity. You should do, so capacity exists, and again, this is their consensus statement. You should have judicious patient selection. I think you should always have judicious patient selection. Offer VV, VA in selected COVID-19 patients based on usual criteria. Offer ECMO for non-COVID indications, and ECPR only in expert centers. I don't think you should do ECMO if you're not in an expert center. It's one thing to initiate ECMO and have the cavalry come to get the patient out of there, or the cavalry come and initiate the ECMO and take your patient. But if you're not an expert center, and I'm not sure exactly what qualifies as an expert, but if you've never done ECMO before, you've only done one in 3 or 4 years, you shouldn't be trying to start that now. That's my view. You want to do an ECMO program, it takes a tremendous amount of planning, organization, training, support, There's a lot of factors involved. It's just not like a dialysis machine, no matter what the manufacturer's representatives try to convince you of. Capacity, Tier 1, system is running within expanded capacity. You should triage to maximize ECMO capacity to outcome. Is outcome 30 days? Is it 180 days? Is it short term? Is there quality of life, health-related quality of life questions involved in this? Those are all decisions you have to make and figure out what is survival to you. Getting decannulated or leaving the hospital and having a relatively normal existence. So those are the questions you have to ask yourself, and there's a lot of things in between. But you're at expanded capacity, triage, V-V ECMO in younger COVID-19 patients with single organ failure, judicious ECMO use for non-COVID-19 indications. Now, that kind of irritates me. It's their consensus statement, and I like ELSO, but that irritates me. So if you have a need for V-V ECMO and you don't have COVID, then you're somehow, if you're aspiration pneumonia, those have great outcomes. You should be more judicious. No, I think that non-COVID diagnoses have far better outcomes than COVID does. So why would we restrict that? That doesn't make sense to me. And eCPR should not be offered. I don't agree with that either. In expanded capacity, close to saturation, you should have restrictive ECMO selection criteria, and VA ECMO and eCPR should not be offered. Again, I like ELSO. I understand what their reasoning for this is, but if you do a case and the patient's got some RV or LV dysfunction and just needs a little bridge to recovery for a few days in VA ECMO, but you're at capacity or nearing capacity, you're on the expanded capacity with COVID ECMOs, I don't think that patient deserves less. I don't agree with this. I mean, it's just as simple as that. In crisis capacity, the system is overwhelmed. ECMO may no longer be appropriate. Concentrate resources to usual care. So your capacity is overwhelmed. ECMO is not feasible in either COVID or non-COVID patients. Triage ICU admissions. Consider ceasing all fetal care to create capacity in the system. Well, I mean, I do agree with that. If you have fetal care, you have fetal care. But again, just because we're at capacity doesn't mean we can't. We have a capacity for the hospital. We have a capacity for ECMO. Certainly we should be, if we're at that level, highly selective. But I can tell you right now, I've been wrong a couple of times where I have been absolutely certain this patient is going to absolutely do great, and they didn't. And I've also been convinced that patient is just simply not going to make it. I don't know why we're doing this. And they've walked out of the hospital. So my predictive skills are very much in question. And, you do that. You have those happen a couple of times, and it really checks you up. And you're not in such a hurry to start making decisions about who's going to make it and who's not going to make it. Sometimes it's obvious. Sometimes it's clear, but there's a lot of gray in there, and I just simply can't really agree with this. I think you got to take care of patients, and if you're overwhelmed and patients could survive without ECMO and you need the room and they're that far gone, you have to accept failure in those patients. But I think if you're highly selective and you have the technology and the patient is already occupying the room, you should at least give them a shot. Maybe not 30 days, 60 days, 80 days, 90 days on ECMO, but a couple of weeks and see if we can turn this around. ELSO does have a disclaimer, so keep that in mind. I would suggest you read it because everything that they say has a disclaimer and we're not liable for whatever decisions you make. All of the decisions, their recommendations are based on available evidence and existing best practice guidelines, ethical principles, and expert opinions, but it's a living document, can be changed, and ultimately it is your decision whether to put the patient on ECMO, not on ECMO, or to cease ECMO in any individual particular patient. So what's our experience? Well, from March 12th of 2020 to March 21 of 2021, we had ECMO in 5 different hospitals, with the majority of them in 3, and we had 47 total ECMOs. Now we're at 52, and this is only for COVID. So COVID patients who are diagnosis of COVID, COVID-associated ARDS, pulmonary failure, and on ECMO for that purpose. So we had 47 within that period of time, 5 hospitals, majority of them in 3, and now we're at 52. But this was only looking at those 47. We had a 20% overall survival, so quite dismal. Survival with a BMI over 40 was 2%. We had no survivors, and by survivors, I mean went home. We had no survivors with a BMI over 45, but one patient who is not in this population had a BMI of 62. He's 35 years old. He was one of those big people I talked about in the very beginning, and he is in renal failure. He is in some element of liver failure, certainly liver dysfunction right now, but he is awake, he's responsive, he's using those little stretch things, resistance bands, to try and exercise himself, a tremendous will to live. He's on a trach collar, and it's heartbreaking. He has young children and family that loves him. He's still in the ICU. I don't know where he's going to go. I don't know if he is actually going to survive. He's got certainly a lot of problems. Another patient that's not in this had a BMI of about 36, maybe 38. He has just recently, after a very protracted, he was on ECMO for 33 days, and he is in a rehab unit. He did have no anticoagulation strategy. He had an intracranial hemorrhage. But nevertheless, they're not in this group because, again, now we're at 52 of them. This is just 47. But I do want to mention that patient who had a BMI of 62, but young, 35 years old. Average ECMO duration was 14 days. Range was 3 to 38. 33 were male, 14 were female. 24% of them of the survivors were male. 2% of the survivors were female. 1. Discussion points from my perspective. Our experience has much lower survival than other published data for COVID, and I frankly think we do a really good job with it. Notwithstanding the published exceptional cases, a BMI over 40 and COVID is devastating. We do have that one younger person, and you saw that study I showed you with a 79.6 BMI, and that was again, what are we calling survivor? We have to really examine what we consider that. 80%, this is such an important point, 80% of our survivors, again, that means they went home. So 80% of the 20% of survivors that we've had in this particular group from March to March were before 2021. So the first wave, very important point. And something changed. It wasn't the virus that changed. Let me elaborate if I may. My theory, which is untested, is during the first wave, this was very novel, and care was very aggressive and very rapid. Volume of cases were low, and later, mostly due to overwhelming number of patients, what we saw from the first wave to the second wave was delayed initial care, delayed transfer to the ICU from the floor, delayed intubation, and delayed ECMO decision. Longer time on vent, but I don't have that exact data of how long they were on, but it was a longer period of time. Patients had, in my theory, a protracted oxygen debt and stress environment on top of the inflammatory process that was triggered by the COVID itself. So that later resulted in this sclerotic and later fibrotic lung disease and low volumes, high pressures, spontaneous pneumothoraces. Many of them were tension pneumothoraces that we had to put chest tubes in, and they became hemodynamically unstable. It was one after the other. And I'm going to show you some radiographs. Here is a patient who was not a survivor. Here you see a tension pneumothorax on the right side. Here's the lung. And I want you to notice something. Just look at that lung. And this happened, by the way, on both sides. We did thoracotomies on this patient. We tried to do wedges on them. We did a lot of things to try and save this patient, but it was to no avail. They weren't a transplant candidate, mostly due to size and the renal failure. Here is another patient that developed a tension pneumothorax, and you can see this very hyperdense lung, very high reflective lung. Here's your tension pneumo here. And as soon as we put a chest tube in this lady, as soon as we put it in, she popped the other side. As soon as we put it in. I want you to look at these radiographs together, very important. This is a non-COVID patient with a tension pneumothorax. You see the lung looks kind of like a cloud that you can see through. It's kind of fluffy. This is that patient that I just talked about. Look at the density of that lung. It almost looks like a piece of stone. And this is what's happened to these lungs. This is how it should look on this side. But look at how it looks over here. And this was one of the big problems we had. So what are our specific perfusion responsibilities? Well, I'm going to start with the yellow one first. What is our professional responsibility when dealing with a dangerous infectious disease like COVID-19 or Ebola? You could pick any number of different things. What's that one from Korea? Hantavirus. There's all kinds of things that we have to treat as clinicians, and I think that I'm going to start with that one first. What is cowardice versus courage? And I'm going to go a little off track here. To see the right and not to do it is cowardice. That's from Confucius. Fear has its use, but cowardice has none. That's Mahatma Gandhi. The definition of courage is the ability to do something that frightens one. And if you look at that red circle, I won't get into the details of what this is, but there was a school shooting in Florida. In the circle is the school resource police officer who was there to protect everyone there. He is hiding behind a building while the shooting is going on around that corner in a different section of the building versus running towards it. As medical professionals, and I had this happen very early on, John, I'm kind of curious if you saw this at all. I had some people say, I'm in a high-risk category. I can't take care of COVID patients. No, it doesn't work that way. When you decided to get into healthcare and you decided this is what you want to do and you enjoy the recognition that you get from society for being in healthcare at the level that we are in healthcare, you don't get to say, oh, no, I can't take care of those patients. That is your responsibility. And so I want to point that out. John, maybe you can talk about that for just a moment. Did you have any of that occur? Because I did.
I have one friend of mine, who I won't specify the field of practice that they're in, or anything else for obscurity. But in the midst of all this COVID frenzy, about 4 to 5 months in, I was texting him trying to find out, how things are going, what are you guys seeing, and all that kind of thing. I even was inquiring about if he could come down and help us with the overwhelming we had. But at any rate, had just was informed by his doctor that he was pre-diabetic, that his glucoses were running a little high. He wasn't diabetic, but he was pre-diabetic, needed to make some changes to his diet, maybe needed exercise, wasn't going to go on any treatment for it or anything like that. But in the process of COVID being only 3, 4, 5 months old, as you recall, the hysteria was, pretty off the charts with what are we dealing with here. Was told by this same physician, you're now, you're in a high risk category now, and I would say, be cautious about working around COVID patients. So he pulled back. He let us know that he wasn't going to be able to come down and help us out and things like that. So that's the only one that I had direct experience with.
Well, and I appreciate that. Our response, my response was you don't get a choice, and you either have to take care of the patients or you just simply don't have a job. It's as simple as that. I think that I'm in a high-risk category. I was scared, but we don't have a choice. You're in a high-risk category, just based on our age. So I think that was something that I wanted to point out, because this isn't the only time we're going to see this. And I wanted to give this message to people that when you're dealing with something that frightens you, as Mahatma Gandhi said, fear is useful, but cowardice is not. You have to be able to overcome your fear and do the right thing and take care of these patients, because they need us. And that's it. That is what we signed up for. We're volunteers. Okay. What is the specific role of perfusion? And John, I really want your input on this. But clearly, the equipment, the circuit, simplicity versus versatility, safety in CVVH and adding things to it, adding volume, adding blood, whatever it may be. Visibility, you got to be able to see it. Flow, all the things we do as perfusionists. Charting, volume, or chattering rather, and adding volume, cannula protection, turning the patient, cleaning the insertion site, measuring effectiveness, recirculation, like with the ELSA meter, maximizing for lung protection vent strategies to be able to protect the lungs. That's what we're there for, right? Anticoagulation, and providing an oxygen-rich environment for the patient to perfuse themselves. Anticoagulation, monitoring and measuring that, making sure we're not clotting things or we're not bleeding. Temperature management, because we can mask a lot of infections. We can mask a fever with our heater coolers. You got to be thinking about that. Remember that. Consulting with the physicians, doing neuroassessments, perfusion assessments, and of course laboratory values, and making sure that you're keeping a good homeostasis. What else is the role of perfusion? Well, helping turn the patients and clean them, because you want their bowels to work, and if their bowels are working and they don't have a rectal tube in because they don't have diarrhea, liquid stools, they're going to need to be cleaned, and rectal tubes will leak as well. But these nurses are working hard, and if you got to get in there and help them clean them, get in there and help them clean and help turn the patient. I think that is part of our role, not just sitting there and saying, I'm just monitoring the ECMO, that's all I'm doing. Changing bags on the CRRT machine. If they're busy, why not? Help them out. Giving transfusions and volumes as needed through your circuit. Basically anything to help the team, but at the end of the day, especially the patient. That's what we are there for. How should the physicians, perfusionists, and nurses consult with one another? That's a great question. And Dr. Go and his colleagues from Singapore did a study on the impact of an ECMO intensivist-led multidisciplinary team on V-V ECMO outcomes. And they found, published in Critical Care Explorations, and they found that an ECMO intensivist-led multidisciplinary team approach is associated with improved outcomes in patients initiated on V-V ECMO for severe acute respiratory failure. And I think this is very important. We won't go over it too much because I kind of am running out of time. But basically, they're in-hospital mortality, ICU mortality, ICU length of stay, and nosocomial infection rates, all statistically better with an intensivist-led, or the fact that it's intensivist versus somebody else, a pulmonologist or cardiac surgeon, it doesn't really matter. Somebody's the leader of the ECMO patient. I think really the point here is that they have a multidisciplinary team with someone who is actually in charge of all of the patients, not, well, that one's mine. I just put the cannula in that one. This one here I'm actually taking care of, and I don't know who's taking care of that one. Oh, that's the pulmonology, and that's intensive care, and that's somebody else. There's one person or one group that is actually managing all of the multi-interdisciplinary care of the patient. I think that's what the takeaway is. Here's just a diagram of what I just said, the blue being pre-team, the orange being post activation or initiation of their team approach. And they have some interesting, I think, comments from this, that in January of 2018, there was a dedicated ECMO specialist team, ECMO care team, as they call it, which was led by a group of ECMO intensivists with accreditation in critical care medicine and fellowship training in an established ECMO center, or completed an ECMO training course with at least 1 year of experience on an ECMO team. Assessment of patient suitability for V-V ECMO was a joint team decision rather than an individual one, and other members of the team consisted of other intensivists, CV surgeons or CT surgeons, perfusionists, specialized ECMO ICU nurses, I think that's very important, respiratory therapists, I think that's very important, pharmacists, that would be clinical, intensive care clinical pharmacists. These people are extremely bright, continue to provide. That's their team. And that's how you should be delivering ECMO, not just hit and miss, or who's making these decisions, and you have 4 or 5 different services all disagreeing on what to do with the patient. You need one group of people who work cohesively together, and everything filtering down and up through them before it's actually done to the patient. That's my opinion. And so here we go on how you should wear a mask now that we're finally getting rid of a mask, and the green check apparently being the appropriate way. The bottom left is anesthesia. I think the one on the top right is perfusion. And I just, all the rest of them, you could pick a discipline for them however you would like. But thank you very much. I appreciate your time listening to me. I know that was a long, laborious presentation with a lot of information, but the phone lines are open if anyone wants to call, because you could win a T-shirt, a ball cap, a surgical cap, something like that if you'd like to. I won't spin the wheel if nobody calls, so nobody's winning anything if nobody calls. And, John, you're ineligible, so there you go. So anyway, so what did you think, John? Did I do this topic justice, or is there any other comments that you have, or something you'd like to clarify from my statements?
You did a great job. That's I don't know where you found all those great slides. So many of them I haven't seen. I don't want to harp on the ELSO thing too much, but I made a couple notes here. When you talked about it goes a dozen or 2 dozen slides back, and it said something about that that they were recommending maximum support strategy,
Mm-hmm.
to do the maximum support strategy, but they left out 3 words. For how long?
Mm-hmm. Mm-hmm. Yes,
okay,
that's...
they have to think about the
Mm-hmm.
words that they're using.
Mm-hmm.
These words, and you said also, when that one part a few slides later, where they're talking about, ECPR should not be offered. Well, maybe ECPR should not be aggressively offered, so you don't just consume all your equipment. But we have to do ECPR because we have patients on the bubble. We're trying proning, we're trying everything we can. They suddenly jump off that bubble and go downhill. they're ready for ECMO if that one little leg drops worse, and we run in there with ECPR. So you can't say it's not offered, like, period. I mean, if you're going to be an ECMO center, then, you know, they're trying to tell people who are new centers, don't go crazy putting everybody on ECMO. Try to conserve your equipment for the younger, the ones that have more opportunity to heal. But your experienced centers, I don't know if some of that even applies, because we already have management of what we know we're going to do with what patients when. You follow what I mean? So that was the else. So they have to be careful with their words and who's reading that.
Yes, I totally agree with you. Well, I think you just brought up two very good points. First of all, notwithstanding COVID certainly did stress our system. Here in Houston, it stressed us a tremendous amount. And we were operating not only on expanded capacity, but we were at capacity limits a number of times during this period of this year. And a 44-year-old, 42-year-old hits your ER with an acute occlusion of their big LAD, and they're in cardiogenic shock, and they can't get them stable in order to be able to open that up with balloon angioplasty and a stent, or maybe even, you know, the need for cardiac surgery. I don't think you just say, no, we can't offer it to you because here was an ECMO circuit and we have it, but, you know, ELSO says we really shouldn't offer this right now. I think that's absurd. It's absurd. The second point that you brought up that I think is very important is the time. That clearly earlier time, and my theory is untested, but I believe in it. I'm really curious to see what the histology of these explanted lungs from, hopefully they've done them, or wedge resections that have been done, or lobectomies that have been done on these patients that have COVID, that have these real stiff lungs, or these transplants that have been done for patients, what the alveolar capillary membrane actually looks like, what actually is happening there, because I am convinced it is a double-pronged, a two-pronged inflammatory response. The first one from the actual virus itself, and the second one from this oxygen debt stress environment of not being able to breathe, that just that goes in there and just destroys the lung with gross infiltration of leukocytes, and then thickening sclerotic changes, and then later converting to fibrotic and lung irreversible fibrotic changes of the lung. That's what I believe is happening.
Well, we saw a lung transplant from a COVID patient who had just absolutely terrible lungs after the bout of COVID, and ended up getting a lung transplant. So we were able to see the COVID lungs, and they're unrecognizable. They're unrecognizable.
Well, can I show you something?
Yeah, show me.
Can you give me 1 second? I'm gonna mirror my phone, but don't switch it over until, because I need to make sure that I don't violate any HIPAA things or.
And while you're doing that, I'll just comment on the other slide you showed that had the survivability that you said post, I think 2020 and 2021, you had 8 male survivors at 9% or something, and then 1 female survivor.
Yes.
And I don't know if there's enough numbers there. You did quite a few. You did 47 in your study, all COVID ECMO.
Yes.
And
just COVID. Our non-COVID ECMOs, much better outcomes, because we had several.
Now,
they did great.
The other thing I would comment too, and I think you made a very good point. This is what I think happened you said the virus didn't change. I can tell you what did change. Whether the virus did or not, I'm not an expert, but I can tell you what did change. COVID hit, and if you had COVID, all doors flung open to you. We need to see you. We need to come into the ER. We need to treat you. So it started to sprinkle. Then it started to rain hard. Then it started to hail. Then it started to hail hard. What I mean by that is the hospitals had patients everywhere. So when you called with COVID, now the onslaught was protect us from the storm. us as being overwhelmed. So I know people that came down with COVID. It was you didn't move out of your house. You had a phone call and they told you stay home, don't come in, don't everything was about pushing the patient off because we're overwhelmed.
Correct.
And you don't come into the ER. Do this, and the other thing. I know people didn't even get a prescription. The doctor just said stay home, do certain things. Let me know how you do in a few days. Until you got hypoxic, were you allowed to even come to the ER?
Yeah. They told you to get a pulse ox. And that's another very good point. And that's true. And I had pointed that out, delayed care. That is absolutely, I think, a tremendous contributor to this versus in the early days when you just got fast-tracked. There was no delay. But I also think we are not blunting the inflammatory process. And I don't know if it's, I don't know, I don't want to say the names of them because I don't need YouTube to be doing anything here, but, some of the anti-parasitic drugs that, no, it doesn't work. Other people are saying absolutely it does work. The dexamethasone, are we using that aggressively enough? In the early days, it was don't use steroids. Now it's, no, we're not using enough steroids. I don't think we're treating their inflammatory process aggressively enough, but I think that when you say hypoxic, it's to what level of hypoxemia. So if you're running at a low sat, like you're trying to walk around on a 15,000-foot mountain and you're struggling and your lungs are getting wet and stiff, that in itself, there's going to be anxiety. You're putting the patient, not from that alone, but obviously that's a contributor, but all of that stress of anxiety and hypoxia and hypercapnia and all of those things, not being able to eat, not being able to drink, not all of that is going to severely affect your inflammatory response, and it's going to exacerbate an already existing inflammatory process just from the COVID itself. So let me show you these lungs. This is what COVID lungs look like. Do I need to share it again? No, thanks. That's what COVID, can you make it big, or is that as big as it gets?
It looks like a liver,
It does. Is that as big as it gets? Oh, no, there you go. Oh, that's good. That's nice. I like that. And here's another view.
Too bad you don't have a picture of normal lungs.
I do.
It wouldn't look anything like that.
I do.
Okay, good.
Just not next to it because I'm on my phone. But these are explanted lungs from a 26-year-old young man.
Yeah, I bet that weighs many, many times heavier than what it should.
Sure.
It's dense. It's
and these are his new lungs.
Yeah, exactly.
That were delivered.
They're unrecognizable.
And here's another view of his, a little more close-up of his new lungs. I mean, that's a beautiful organ. That is what it's supposed to look like. And this, going back to it again, is what the explanted lungs on a 26-year-old look like. And I think I can just quickly, let me see if I can do this. Here, can you take that? Can you take that away for just 1 second so I can? Okay, thanks. Let me see if I can do this. Here, just give me 1 second. I'm sorry, but I want to make sure that I pick the right picture. Hold on.
Well, Joe, I think it'd be interesting if in another 6-9 months or so you continue to add your COVID numbers to this preliminary 47. Continue to collect the data, and we reconvene, later this year and see if your numbers, what your numbers are, and it'd be interesting to keep dissecting out 2021 from 2020 numbers too.
So here's this young man. Yeah, I agree. Here's this young man going home. And no oxygen. He does, of course, reads the plaque, rings the bell, and from the transplant center, but you could see how skinny he is.
Mm-hmm.
So could you imagine? This kid's 26 years old.
Mm-hmm.
Could you imagine what this does to a 40-year-old, 50-year-old, 55-year-old, 37-year-old who wasn't, and this kid was young and in good shape. And you could just see yourself what ECMO at a hospital, transfer from there after several days, or actually a couple of weeks on ECMO, to the transplant hospital, to the quaternary care facility in the med center. He ended up on a second ECMO circuit. So 2 ECMO circuits, because he's a young kid, 26 years old, high metabolism, and to get him to where they actually moved him while he was, you could take the picture down, thanks, man. They actually ambulated him on a double ECMO circuit, like you were talking, V-V, and he conditioned himself enough to go ahead and get the transplant. But I'm very curious to see what those lungs, what the necroscopy and also the histological findings of those lungs ends up being.
Yeah, I think that my thought here, if we, from a medical standpoint, and if we could flash forward 10 years or maybe longer in the future, I think this is going to be a lesson in inflammatory responses, and what we need to open a whole frontier of treatment on subduing these inflammatory responses far greater than what we're doing now, which is almost nothing. Actually,
Specifically
right?
for the lung. So is it unfractionated?
Right.
Is it nebulized unfractionated heparin? Is it nebulized surfactant? Is it dexamethasone? Is it the antiparasitics, that were discussed, earlier on, and one a little bit later? I don't know. I certainly don't know the answer. What I do know is that what we're doing is marginally effective.
Yeah,
you save one, okay, that's important. That person, it matters. But how many didn't we save that we could have saved? And is that because of selection? Is that because of lack of appropriate treatment or lack of understood best treatment? Not certainly on purpose. And then, of course, the other thing that I worry about is the number of new ECMO systems you actually did a great lecture on this very topic. In one, I think it was one of your knowledge nuggets, if I remember. No, it wasn't. It was just a lecture. I don't remember exactly how it came up, but you talked about a whole bunch of different circuits that were out there, and it's worrisome to me that hospitals are, we just have to have an ECMO circuit, and we're just going to do this. It's definitely concerning me, and it's something that I think industry is contributing to in a negative way. They did the same thing with the Impella, for example. We need to get it in everywhere, and really it just doesn't need to be everywhere. I think that you need to be able to get those patients someplace else. I don't necessarily believe in centralization, but I do believe in regional centralization, if you will. So if you have this region, you should have one center that does this because it's so invasive, so multidisciplinary, requires so many resources and skill that if you have too many doing few, it's kind of like transplants. You can't just open a transplant program up because you want to open a transplant program up. You're not allowed to do that because you have to have the volume to be able to be good at it. And I think we should be doing the same thing with ECMO.
Yeah, I mean, you talked about the inflammatory response of the disease. It's the body's inflammatory response, to the disease. But then we add ECMO, which is a whole nother gigantic inflammatory response on top of the original inflammatory response. You add hypoxemia, either pre-going on ECMO, which is what led them to be on ECMO. You might even still have hypoxemia on ECMO. So now, you have the inflammatory response of the body's own inflammatory response to the disease. For whatever reason, this is what this COVID virus is doing. Then the ECMO comes in, another, drop another gasoline on that fire. Then you have, the hypoxemia, which, what is that doing? There's probably tremendous body response to that. And most of this is focused on the lungs, but there's also multi-organ inflammatory damage that's going on. And that's why I was saying earlier, I think if there's a field of research that we can say, in a state of inflammatory response, even if it's a minor or major one, what can be the new avenue of science and medical research that says we need to do A, B, C, D, and squelch inflammatory responses 70–80% in any situation. And I think that we would probably see tremendous improvement in what's happening with COVID and of course COVID ECMO.
Yeah, but I do think it has to be somewhat specific, because obviously you can't just completely immunosuppress someone, because you'll have all these other problems that are going to happen. So you have to be able to target what you're trying to target, and I think that's going to end up being an inhalation treatment versus a systemic treatment, or a combination of both. That's potentially.
I was also referring to the elimination of, or the removal of, far more effective removal of the inflammatory response. I don't think you can't really immunosuppress these people. They're running so many risks to infection as it is. I mean, we have infection risks left and right. I don't know what would happen. So I'm more talking about something that doesn't even, I'm talking about an unknown. But like I said, 10, 20 years from now, if we can have whether it's a CRT device or something completely different.
Well, like the really Cytazorb, they have the Cytazorb.
Yeah, they have it.
They have other, other molecular adsorption technologies. So,
How much is that reducing the inflammatory response COVID ECMO patient? 5%, 10%?
I don't know. I don't know.
I don't know. I did one the other day. We had that on there, and I had people tell me, oh, it's doing tremendous. And I had another CCM say, I don't think it's making any difference at all. So I have to research that myself. I don't know.
Yeah, I just don't know. I don't have any experience with it. It seems to make sense. I understand it, but I've never used it, so I just simply don't know. Okay, John, without any further, if you have anything else, if not, I'm going to close out with telling everybody PerfWeb 61, which is going to be the VUMC, that's Vanderbilt University Medical Center, Department of Cardiothoracic and Vascular Surgery. Faculty Forum will be Wednesday, June 2nd, 2021, starting at 6:45 a.m. or 7 to 8:30, and it's going to be VADS Part 2, which is going to be Dr. Jordan Hoffman. He'll be joined by Matt Warhoover, perfusionist, the associate director of the program, and also Tony Lepore, a perfusionist. Really incredible guys. These are very, 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 very experienced VAD and ECMO folks. They're going to be talking about VADs. Dr. Hoffman's lecture is going to last about an hour and a half, so I think it's going to be very comprehensive, followed by Tammy Sparacino's Journal Club, which is going to be lower versus higher oxygen targets for acute hypoxic respiratory failure. I think that's going to be very interesting. And then John is going to be rounding that day out with his Knowledge Nuggets. That's going to be 9:30 to 10, and it's going to be on atrial septal defects. So, and this is approved for this whole day. Of course, it starts at 7 and ends at 10, so it's approved for 3.4 Category 1 CEU by the ABCP. So listen, we're providing you with more than enough opportunities to get all of your CEUs for your ABCP recertification. So very affordable. Hope you check us out and do it. But John, thank you so much for bailing me out today and helping me. Your insights were very well thought out and coming from very experienced eyes, and we appreciate that a great deal. And we'll look forward to seeing you Wednesday, June 2nd. Good luck on your house adventure in Key West. I only wish I was an ECMO center perfusionist and can afford a house in Key West, but I can't. So I appreciate that very much, and hopefully I'll get an invitation to come out and visit you, and we will do a program from there one day. That would certainly be a lot of fun for me.
They're building a brand new Margaritaville resort, Joe. Perfect for you. You would love it.
Outstanding, outstanding. I'll take the tequila without the sugary stuff. So I'm just more than happy with just straight tequila. But I'm currently on sabbatical from Jose Cuervo, so I haven't had any of that in a long time. But hopefully one day I'll be able to have a little sip. I wish everybody a wonderful Thursday. I'm glad COVID is reducing. I hope everybody has stayed safe and your families have stayed safe, and we're looking forward. Thank you for the support. It's so appreciated. We will look forward to seeing you on Wednesday, June 2nd. Good night.
Nice job, Joe. Nice job,
Thanks,
Joe.
bud.
Good job.